So pathology and pathogenesis of Eale's disease. The classic histopathological the classic histopathologic connotation of the term vasculitis, connotation means meaning, earth, of the term vasculitis is type 3 hypersensitivity reaction with deposition of immune complexes in the vessel wall leading to vessel wall destruction. This rheumatological definition is not applicable to retinal vasculitis in general, particularly in Eale's disease, which represents perivascular coughing with inflammatory cells, traded by clinical appearance rather than vascular caliber or type of immune response. So what they are saying that it is not typical of the vasculitis or type 3 hypersensitivity reaction where the deposition of the immune complexes is seen in the vessel wall and that leads to vessel wall destruction. That is the rheumatological definition of the vasculitis, but in case of Eale's disease, this definition is not completely applicable here. Because here there is a perivascular coughing with inflammatory cells. There is no destruction as such, and graded by clinical appearance rather than vascular caliber or type of immune response. So we don't say that it is this type 3 hypersensitivity response and there is destruction of the vessel wall. Yes, there are inflammatory cells in the vessel wall and perivascular coughing is there rather than destruction. So most authors have therefore used the terms vasculitis and perivasculitis interchangeably. So it is not exactly vasculitis. They are saying that it is perivasculitis interchangeably in the context of Eale's disease. Central to the visually debilitating complications of Eale's disease is retinal hypoxia. Inflammation causes hypoxia by an increase in the metabolic demands of cells and a reduction in metabolic substrates caused by inflammatory vascular occlusion. So complications are because of the retinal hypoxia, obviously. So whenever there is inflammation by there is hypoxia, then increase in the metabolic demands of the cells, reduction in the metabolic substrates caused by the inflammatory vascular occlusion. Hypoxia in turn triggers further inflammation, setting up a vicious cycle. This sequence suggests a pathogenetic role for both angiogenic factors and inflammatory cytokines in Eale's disease in a manner similar to non-inflammatory vascular diseases such as diabetic retinopathy. Simultaneous upregulation of the vascular endothelial factor VEGF, chemokine monocyte chemoattractant protein MCP1, and interleukin 6 and 8 has indeed been observed during the proliferative phases of both diabetic retinopathy and Eale's disease. Other biochemical analyses have also implicated retinal autoimmunity, angiogenic growth factors, and oxidative stress in causing inflammation and neovascularization in Eale's disease. A unique 88 KDA means kilodalton, iron binding protein. Kilodalton is a measure of molecular weight. A unique 88 kilodalton iron binding protein with antioxidant properties isolated from the serum and vitreous of Eale's patients was characterized by a proteomics study of proteins. Proteomics means study of proteins based approach as a complex of heptoglobin, complement C3 and galactin-1, suggesting a complement mediated mechanism of inflammation. So it's just molecular level pathogenesis of Eale's disease. I don't think we need to remember all these things. We'll just go through that thing. Suggesting a complement mediated mechanism of inflammation in Eale's disease. The role of oxidative stress is also supported by increased expression of copper transporter 1 protein identified from the autopsied ocular tissue samples of Eale's patients. Other serologic and genetic studies suggest the role of cell-mediated immunity in Eale's disease. So there is a complement mediated damage or inflammation. Then there is cell-mediated immunity in Eale's disease. Other serologic and genetic studies suggesting the cell-mediated immunity in Eale's disease, particularly interleukins and tumor necrosis factor alpha, interleukin 6 and 8 that we have just seen. Raised serum homocysteine has also been proposed to cause both vascular damage and oxidative stress in Eale's disease. The pathogenesis of inflammatory vascular occlusions in Eale's disease remains unclear. So the pathogenesis of inflammatory vascular occlusions in the Eale's disease remains unclear. Systemic association with neurologic, vestibulo-auditory, hematologic and parasitic diseases and infections has been proposed but never proven. So systemic association with some diseases and some conditions, systemic conditions, infectious diseases and systemic conditions like neurological manifestations, diseases, not manifestations, neurologic conditions, vestibulo-auditory conditions, hematologic and parasitic diseases and infections has been proposed but never proven. The most frequently reported association is with systemic TB. This is important. Tuberculosis. Most important systemic association with Eale disease is tuberculosis in India. Although viable organisms have not been demonstrated from eyes with Eale disease, polymerase chain reaction based studies have identified mycobacterial DNA in vitreous and epiretinal tissue. So what they found? Mycobacterial DNA in vitreous and epiretinal tissue. But they didn't demonstrate the viable tuberculous organisms. These findings make the case for hypersensitivity to tuberculoprotein. The case is reinforced by the presence of tuberculin skin test positivity in the majority of the patients. Though other studies disputed this notion by demonstrating Mantoux positivity in healthy controls and Mantoux negativity among Eale's patients. Tuberculin skin test positivity was reported in 64% of the patients in the largest case series on Eale's disease. Differential diagnosis of Eale's disease. Eale's disease is a diagnosis of exclusion. Several ocular and systemic inflammatory and non-inflammatory diseases cause retinal vascular sheathing and occlusion, which may closely resemble Eale's disease. However, a battery of investigation is not necessary for every patient. A detailed history and a thorough systemic examination rule out most mimicking diseases. A few tailored investigations can clinch the diagnosis. So there is a flow chart related to differential diagnosis of Eale's disease. BRVO stands for branch retinal vein occlusion, IRV idiopathic retinal vasculitis, PDR proliferative diabetic retinopathy. So this is a flow chart revealing the differential diagnosis of Eale's disease. So differential diagnosis of Eale's disease: non-inflammatory retinal vascular diseases, inflammatory retinal vascular diseases. Non-inflammatory retinal vascular diseases can be proliferative diabetic retinopathy, branch retinal vein occlusion or others. Inflammatory retinal vascular diseases, primary or secondary. If it is primary inflammatory retinal vascular diseases, it can be Eale's disease or idiopathic retinal vasculitis or others. Secondary, it can be ocular or systemic. Ocular inflammatory retinal vascular diseases can be intermediate uveitis and others. And systemic inflammatory retinal vascular diseases, which are secondary, can be infectious and non-infectious, and infectious causes tuberculosis, syphilis and others. Non-infectious diseases, sarcoidosis, Behçet's disease and others. Differential diagnosis of Eale's disease done. Now the flow chart is done. Among non-inflammatory vascular occlusions, primary branch retinal occlusion mimics Eale's most closely. The former occurs at an arteriovenous crossing. The crossing artery is frequently sclerosed. The occlusions are not multiple and peripheral as in Eale's, and they affect older age groups. Proliferative diabetic retinopathy may also exhibit sheathing of vessels during the active stage, characteristic of featureless retina, or at the involutional stage. Central retinal vein occlusion in a young adult should be investigated for inflammatory etiology. See diagnostic workup for Eale's disease later in this chapter. Because it represents a rare presentation of Eale's, Coats disease, familial exudative vitreoretinopathy, and sickle cell disease also show similar peripheral non-perfusion and should be ruled out. Peripheral non-perfusion is seen in Coats disease, familial exudative vitreoretinopathy, and sickle cell disease. Though Coats disease also occurs unilaterally in male patients, Coats disease and Eale's disease similarity. unilaterality and occurs, this Coats disease also occurs in male patients. Those with Coats disease are younger. Coats disease patients are younger with more prominent telangiectasia and lipid exudation, more exudation, and with less neovascularization or vitreous hemorrhage, less chance of vitreous hemorrhage and neovascularization in Coats disease. Similarity between Eales and Coats is male patients unilaterality, but difference is that age of presentation is younger in Coats and it is 20 to 40 in Eales. And then in Coats disease, prominent feature is telangiectasia. Periphery is involved, but there are telangiectasia. Telangiectasia means abnormally dilated vessels, especially capillary and venules, and less vitreous hemorrhage and less neovascularization in Coats disease. Now, familial exudative vitreoretinopathy. In familial exudative vitreoretinopathy, what we see is the periphery of the retina is incompletely vascularized. It's not completely vascularized. There is no development or less development of the vessels in the periphery of the retina. But it is not similar to retinopathy of prematurity. Retinopathy of prematurity, obviously the periphery are not vascularized. They have not reached the periphery in premature babies. But in FEVR, familial exudative vitreoretinopathy, the baby is full term and mature, normal weight, but still the vessels have not reached the periphery. The periphery is avascular. So that is familial exudative vitreoretinopathy. And sickle cell retinopathy. What is sickle cell retinopathy? Obviously, there is a hypoxia. Why there is a hypoxia? Because there is point mutation in beta globulin chain of the hemoglobin, and that causes the sickling phenomenon, aggregation of the blood cells, obstruction of the capillaries and venules under the hypoxic conditions, and that sets in the vicious cycle of hypoxia and inflammation, and that leads to neovascularization. And also sickle cell retinopathy, peripheries are involved. So we have to differentiate between the Eales disease and FEVR and sickle cell retinopathy and Coats disease. Now FEVR, familial exudative vitreoretinopathy, and sickle cell retinopathy have distinctive clinical and angiographic features. They have distinctive clinical features and angiographic features. They are distinctive, and familial and systemic association is there, respectively, to distinguish them from Eales disease. Eales disease is more localized, and these are multisystemic environment is there. FEVR and sickle cell. Ocular inflammatory conditions such as intermediate uveitis, endophthalmitis, multifocal choroiditis, and birdshot retinopathy may have associated retinal vasculitis, but primary lesions are generally prominent and unmistakable. Among systemic infections, both active and latent tuberculosis. So other inflammatory conditions, uh, intermediate uveitis, endophthalmitis, multifocal choroiditis, and birdshot retinopathy may have associated retinal vasculitis, but primary lesions are generally prominent and unmistakable. Among systemic infections, both active and latent tuberculosis should be ruled out in every case of retinal vasculitis because of TB's global presence, especially among the Asians, because tubercular hypersensitivity is central to causation of Eales disease, and because its incidence follows endemic prevalence of tuberculosis. See introduction. Eale's disease has been proposed to be a manifestation of ocular tuberculosis rather than a discrete entity. Um, Tuberculosis, however, causes exudative occlusive perivasculitis, and it is usually associated with granulomatous uveitis, broad-based posterior synecdoche, multifocal peripheral serpiginous-like and perivascular choroiditis, moderate vitritis, and frequent disc macular edema. So, Eale's disease has been proposed to be a manifestation of ocular tuberculosis rather than a discrete entity. Tuberculosis, however, causes tuberculous vasculitis. What it does cause? And tuberculous retinopathy, what it does cause? Granulomatous uveitis is there. Broad-based posterior synecdoche, iris lens posterior synecdoche. Multifocal peripheral serpiginous-like perivascular choroiditis. Choroiditis is there, but how is it is that it is multifocal, it is peripheral and serpiginous-like, and perivascular choroiditis. Moderate vitritis and frequent disc and macular edema or macular edema. Syphilis-like tuberculosis needs to be screened by default because of its re-emergence with HIV and its varied presentations. Retinal peripheral occurs in about half of the cases of leptospirosis, the most widespread zoonosis globally. Non-granulomatous uveitis, vitritis, and papillitis help in differentiation. Retinal vasculitis can also occur with necrotizing retinitis, though arteries are more commonly involved. In necrotizing retinitis, obviously necrotizing, so arteries are prominently involved. Like tuberculosis and syphilis, sarcoidosis has no pathognomic signs and it needs to be ruled out in most ocular inflammations. Sarcoid vasculitis is typically segmental, nodular, and bilateral with snowball. Bilateral, segmental, nodular with snowball vitreous exudates, and granulomatous uveitis, and obviously multisystemic involvement is there. Diagnosis is usually based on key ophthalmic signs, chest radiography, serological investigations. Although uncommon, Behçet's disease is the classic presentation of occlusive retinal vasculitis along with Silk root. Epidemiologic spectrum of retinal vasculitis. It involves both arteries, retinal infiltrates, and it is accompanied by severe uveitis, vitritis, and retinal infiltrates. Orogenital aphthosis are diagnostic. Systemic vasculitis, such as systemic lupus erythematosus, have been erroneously linked with retinal vasculitis in literature. The retinal effects are typically mediated through secondary hypertension, that is, for example, cottonwool spots, superficial hemorrhage, and manifest as arterial rather than venous occlusions. These things. So, another differential diagnosis for Eale's disease: sarcoidosis, Behçet's disease, which are non-infectious. Sarcoidosis, Behçet's disease, and other. Now, sarcoidosis, obviously, it is autoimmune, but not completely autoimmune disease, they say. There is a multisystemic involvement and hypersensitivity. Then granulomas are there, cascading granulomas, and so in sarcoidosis we see the granulomas, multisystemic involvement, lung is involved, visceral organs are multisystemic involved, visceral organs are involved, CNS involved, eyes involved. So yeah, there is a bilateral involvement is there, and panuveitis can be present in sarcoidosis. And Behçet's disease, again autoimmune disease, orogenital ulcers and aphthous ulcers, orogenital ulcers, and uveitis. Primary retinal vasculitis. Once disease causing secondary vasculitis are ruled out, the two primary conditions that remain in the picture are Eale's disease and idiopathic retinal vasculitis. The term idiopathic retinal vasculitis is preferred over Eale's disease when the following happen. The vasculitis is more posterior, sectoral, exudative, and non-occlusive. The term idiopathic is preferred over Eale's if vasculitis is more posterior, that is near the pole, because Eale's is peripheral. So here, if it is posterior, if it is sectoral, if it is exudative, and occlusive, non-occlusive. So vasculitis if it is posterior, sectoral, occlusive and non-occlusive and exudative. Then vasculitis affects older females more commonly. Actually, Eale's more main and younger people. So if the vasculitis affects older females, then it can be idiopathic vasculitis. Vitritis is common. So Eale's disease, the idiopathic retinal vasculitis is preferred over Eale's disease when the vasculitis is more posterior, sectoral, exudative and non-occlusive. The vasculitis affects older females more commonly. Vitritis is common. Neovascularization, which is hemorrhage and recurrences, are uncommon in idiopathic vasculitis. This pattern of vasculitis is typically described in Caucasians. Immunomodulatory treatment is frequently required along the corticosteroids. This differentiation appears to be semantic. This disease workup remains the same, leading some authors to propose that the term Eale's disease should be discontinued. However, classic Eale's disease has the usual combination of minimal periphlebitis and vitritis, but extensive vascular occlusion and neovascularization, leading to recurrent vitreous hemorrhages in young males, thus justifying the eponym. Eponym is name. Eponym. So part 3 will be on diagnostic workup for Eale's disease and epidemiological spectrum of retinal vasculitis. Management will be the fourth part.